All right. Well, hello, everybody, and welcome to our latest Still COVIDing and Survivor Corps joint chat over Zoom here. Today, we have with us Dr. Robert Groysman, author of the
Hello.
Complete Long COVID Handbooks. And today, Dr. Groysman has generously offered his time to talk to us about two pretty cool procedures that are gaining momentum and evidence behind them to treat long COVID. One of the procedures is mostly only available in Japan, unless you see Dr. Groysman, and the other procedure is available in some places across the US, but Dr. Groysman has done a number of these procedures and seen some really good results. So, welcome, Dr. Groysman. We're happy to have you again with us today.
Thank you so much, Kara.
And we're excited to learn about everyone is always hopeful, but similarly discouraged with long COVID, because long COVID is a complex condition. It's multisystemic. It's obviously a really tough condition for a lot of people, and so to hear that there are actually some medical procedures that can improve people's quality of life is both very interesting and very hopeful. So I don't know which one you want to talk about first, or if you want to tell us a little bit about how you got started doing these procedures, maybe would be a good place to start.
Sure. Dysautonomia is the heart of all this. Dysautonomia is not new. It's been around for many, many years. It's been responsible for many different problems with different conditions, including chronic fatigue syndrome. And I happen to have been treating, excuse me, PTSD, or post-traumatic stress disorder, post-traumatic stress condition, just about when long COVID hit, or COVID hit, right at the end of 2019, beginning of 2020. And I was doing stellate ganglion procedures for the PTSD when we started seeing patients coming in with weird symptoms, which we didn't experience before. It first started with anosmia, which is loss of smell, ageusia, loss of taste, or parosmia, which is abnormal smell, or dysgeusia, which is abnormal taste. And over time, we started seeing more and more symptoms cropping up, including the brain fog, including the fatigue, including the anxiety. And I kind of noticed very close similarity to PTSD in terms of the dysautonomia controlled symptoms. And these patients responded to the treatment, which was also surprising because nobody knew about long COVID. It didn't really exist in 2020. The terminology was actually patient-led or lay-led. And even before it was discovered what it was recovering or improving with the stellate ganglion procedures. So that's basically how I got started with long COVID. It wasn't intentional, it was there, and I just rolled with it. And I continued learning more and more about long COVID and realizing what else was involved besides dysautonomia. Unfortunately, it's not the only cause, but today we're going to be focusing mainly on the dysautonomia aspect of it and how we can treat it.
That makes complete sense to me. Our clinics also sort of fell into long COVID because we were treating post-infectious encephalopathy and that neurological inflammation. And so it was sort of, again, in 2020, like you said, long COVID wasn't really a thing. We didn't know yet about all of the sequelae and how those would come together. But those of us in these spaces that were used to treating sort of these kinds of complex multisystemic conditions just seem to sort of fall into people coming to us for help. So I guess that's good. I guess that's good that we could, we could be there and learn alongside patients how to improve their quality of life. So you said PTSD was um,
PTSD is how I got into long COVID, and for a few years prior to COVID hitting, that's what I was using to treat PTSD, which is managing the dysautonomia aspect of it.
So maybe we should talk a little bit about the sympathetic parasympathetic nervous system and why something that helps PTSD would also help dysautonomia or, improve somebody's long COVID presentation.
Sure. So we can go to the slides if you
Sure.
like.
Yeah, that's what I was thinking is maybe I would just pull up this slide that you provided. So these are Dr. Groysman slides.
Yes. So these aren't my images or anything. I don't own the copyright to them or anything. I'm just using them to portray a point. So we don't really pay a lot of attention to our autonomic nervous system because it is automatic. Automatic. It has two different branches or arms. One is the parasympathetic, which is the one we really want to be in for the most of our time. And then we have the sympathetic, which people know as fight flight. That's more primitive, it's more reflexive, it's more based on kind of more primitive part of the brain. So the parasympathetic part is what controls when we can heal, when we can use our stem cells, when we can repair tissue. It's also responsible for digestion and sleep and rest. In fact, in deep sleep, in basically the stage 3 sleep, is when the parasympathetic nervous system shines. That is when all the good things can happen. On the other hand, the sympathetic, the fight flight, is meant for emergencies, short term, and it's meant to prepare your body to fight or run. It makes your anxiety higher. It can make your heart rate beat faster. Digestion obviously stops. It's not really important when we're talking about life or death. So things that are important to survival is what's active during the sympathetic or the fight flight. Now, unfortunately, with long COVID, the sympathetic is active a lot more than we would like. And in some people, it's active 24/7. So one of the biggest consequences of this is that you can't get deep sleep because it's not compatible with survival. If your body thinks you're in mortal danger 24/7, it's not going to let you get to that deep sleep that you need to recover. That's one of the aspects. On the other hand, we have the vagus nerve and the parasympathetic nervous system, which, as I said, it really is meant for maintenance, basically keeping things status quo and repairing things. And they usually oppose each other. So whereas the parasympathetic would cause your pupils to constrict, the sympathetic would cause the pupils to dilate. So more light goes in. And so you have a bigger field of view. It makes your senses more active. Salivation would be a parasympathetic function, and dry mouth would be a sympathetic function. I think you kind of understand that each organ system just about has influence from the parasympathetic side and influence from the sympathetic side. They have opposing views. They both need to be there, though. I kind of likened it to a driver and somebody sitting shotgun or in the front seat. You need somebody in the driver's seat, and you need somebody to kind of watch and navigate. And what we really want is the parasympathetic to be in the driver's seat most of the time, but the sympathetic is still needed there to keep an eye on things, to make sure that there's no danger or problems occurring. Okay, the problem happens when the sympathetic ends up in the driver's seat and doesn't want to give it up. That's kind of what dysautonomia part of long COVID is. Does that make sense?
It does. And you want to connect the dots for us with the PTSD and the anxiety and the parts of
Yes.
the nervous system?
Yes, of course. So both nervous systems, both the parasympathetic and sympathetic, interface with the brain. And there are several structures in your brain that control your emotions, and how you react and respond to those emotions. And really, the limbic system is where PTSD is involved. And there's a structure known as the amygdala, which stores emotional memory. And in PTSD, your body or your brain is so overwhelmed that it gets stuck in the on position. So you're constantly overwhelmed with those traumatic memories, and the traumatic memories are driving the sympathetic nervous system. And that basically sets the whole process going. So the point of doing a stellate ganglion procedure is to stop this constant on position from the amygdala activating the sympathetic nervous system. The anxiety comes from the fact that when you're in fight flight, that's one of the systems that gets activated. And as I said, the limbic system controls emotions, and anxiety comes from there as well. And if that system is always active, you're going to feel anxiety. You're going to feel panic. You're going to feel fear. All these emotions come from the amygdala.
And with COVID, we have a huge neurotransmitter hit with the histamine component, right? That also causes overactivation of the vagus nerve and throws people into that sympathetic response as well.
That's one of the causes, the MCAS excess histamine. It can also be activated through the gut from a problem with serotonin. It can also come from the dysautonomia, which is the main, I guess, risk factor for long COVID. And lastly, you have the mitochondrial component, which supplies the nerves as well. In other words, if the mitochondria aren't working well in the vagus nerve or the parasympathetic nervous system, again, you'll have an issue with the tone and you'll cause a sympathetic overdrive.
So the SGB procedure is pretty much all about the vagus nerve. So you want to tell us a little bit about the vagus nerve and the SGB procedure and how that's regulating the sympathetic and
Sure.
parasympathetic balance?
Sure. I would consider it more of a sympathetic blocker rather than the vagus nerve. That's what we can talk about with the EAT part more.
Okay. Okay.
So stellate ganglion block, stellate ganglion procedure, what is it? Well, what we're talking about is numbing an area of a nervous system in your neck. It's outside of the spinal cord, it's outside your brain. It acts as a relay. It basically takes signals coming from your brain, including the hypothalamus, including the limbic system, including the brainstem, and processes the signal to the spinal cord and the rest of the autonomic nervous system. Okay? So the purpose of this is to basically stop the output from the stellate ganglion, prevent things from coming in or out. That's essentially, in a nutshell, how the stellate ganglion procedure works. Now, most blocks, when we do regional anesthesia, are temporary. You numb up an arm, and once the local anesthetic is metabolized, the sensation comes back. It may be painful, like for instance, after surgery. If you've had your shoulder worked on and it was numbed up and the numbing wears off, the pain comes back, right? Stellate ganglion works differently. Even though the local anesthetic is metabolized and wears off, the effects continue on. And not just continue on for a few minutes or a few hours, but we're talking about weeks, months, and even years. So this block is, in particular, is different from your usual regional anesthetics. One of the things that it affects, aside from the brain and the nervous tissue, is also the vasomotor response. Now, what we're talking about here is blood flow, okay? So small blood vessel, blood flow, this is what gets messed up during menopause. Hot flashes, sweating, and you also see very similar symptoms with dysautonomia, with sympathetic overdrive. So all of these things are connected, including temperature control, including how you respond to stress, including your heart rate, including blood pressure. All of this gets processed through the stellate ganglion.
And so when we are blocking the stellate ganglion, you want to talk a little bit about exactly how that's happening?
Sure. So the procedure you're seeing on the right was the way it was done. For instance, before X-rays and before ultrasound, a needle was dropped after pulling the carotid artery out of the way, and you hoped you wouldn't get into the thyroid gland or anything else important. And you would touch bone, pull back a little bit, and put in the medication, which is local anesthetic. However, that's no longer how this procedure is done. It was moved over to fluoroscopy, and now most people do it under ultrasound. And the reason
Okay.
ultrasound is so important is because it is excellent at seeing soft tissue. So in this particular case, if you look over where it says CA, that's the carotid artery. And the structure just to the left of the carotid artery is the thyroid gland. And I don't know if you notice, but there's no room between the carotid artery and the thyroid gland. So if you were to drop a needle straight down, you would go through the thyroid gland. So that's not ideal. That's not how we do this procedure anymore. We come laterally. We come laterally and avoiding those nerves that come out of the spinal cord. If you take a look at the two structures labeled AT and PT, AT is the anterior tubercle. This is part of the transverse process or bony structure coming off the cervical vertebrae. And what's important about those two structures is what's in between. That's where the spinal nerves come out. So if you were to drop a needle between AT and PT, you would be meeting Mr. Spinal Cord, which would be very bad and something we never want to do. So it's very important to be able to identify every single structure in that image. And the problem or the issue is that what you see there is not what you're going to see from person to person. The anatomy is very variable, and you have to be able to recognize it each and every time where you need to go and what to avoid. So going from a procedure that was done blind then by fluoroscopy, now it's really standard of care to do this with ultrasound to avoid many of the structures that can be dangerous. So aside from the carotid artery, you have the vertebral artery, which is also visible there. And both those arteries go to the brain, and why it's dangerous if you don't know what you're doing. And you also notice in this image, in this ultrasound image, that the thyroid gland is relatively large and it is touching the carotid. And for the same reason, if you were to drop the needle just like that arrow shows, you would be going through part of the thyroid. Now, it may seem like it's not a big deal, but the problem is the thyroid is full of blood vessels, including arteries. Inferior thyroidal artery is the one that we really want to watch for. It is large. It is very squirrely. It darts in and out of the field, and you really need to know where it is and to avoid it. So the point of this is this procedure has to be done by an expert like myself, and you need to identify all the dangerous structures in any person at any given time.
And how many of these are you doing a month now? I think you told me one point, but it was a pretty big number.
I've done a bit over 4,000 at this point. If I'm not the most in the world, I'm close. But yeah, I mean, experience and repetition is what makes me an expert in this procedure. What we do is a two-level procedure. So the first part is the stellate ganglion, actually, which is going to be at C6 or C7. The stellate ganglion lives at between C7 and T1, and it's composed of two different plexuses or ganglia itself. It's composed of the inferior cervical plexus and the superior thoracic plexus. And in some people, it's not fused, but that doesn't really matter. It still functions as a stellate ganglion, whether it's combined together or not. It still will work with the procedure. And the second procedure, or the second injection, is done at C4, C3, and that blocks the superior cervical plexus. So they both serve a different purpose and have different nerves coming in and out of each plexus. But for instance, the C3 would be more involved with the face and head than the C6 or C7.
And
So,
when Dr. Groysman says C or T, he means the vertebrae. Those are
oh yes, I'm
the
sorry.
letters giving to certain vertebrae in your neck, and depending on where they're located, they have different letters and numbers. So basically, what he's saying is there are two different places that he would inject to block the stellate ganglion.
Yes, so we have 7 cervical vertebrae numbered from C1 to C7. And that's pretty much standard across the board. Everyone has these 7 cervical vertebrae or cervical bones that compose your spine in your neck. And again, identifying which level you're at is also important. You have to be able to read the ultrasound and know which level you're at.
Yeah, and you could come in and you could do either side, but you want to talk a little bit about how
Sure.
you do one side and how you pick that side and what happens if you have to do the other side.
Sure. So this is my own theory or hypothesis. There's no papers on this. This is just from my own experience doing so many of them that I've come up with this. But essentially, there's a dominance. About 90% of people have a dominance to the side that your body prefers to use. It still can use the other side, but it just prefers to use one over the other, just like you have a dominance on your hand. You have 2 arms, most of you, and you prefer to use one, even though you can use both. So if you block the dominant side, that's when you get the effect or the improvement. If you block the non-dominant side, you don't really see a huge improvement or any improvement, and that's because your body doesn't use it a whole lot. So the way we split this up, okay, is that roughly 80% of people are going to be right dominant, and it has nothing to do with being right-handed or left-handed. Your body just chooses one side, and it tends to like the right side more than the left. 10% is left dominant, and 10% rough. These are rough estimates, but 10% are non-dominant, which means that you basically use both sides roughly equally. So both sides need to be blocked. So when you block one side, you'll get a partial effect, and then when you block the other side, you'll get another partial effect, and together you'll get the full effect. So it's a little bit more complicated, but that's the most simple way to explain it. So there's percentages. In other words, one person, even if they're right dominant, they may be 60% right and 40% left, or 70% right and 30% left. So what I don't want is to do an extra procedure if it's not necessary. If a person is happy with it and the effects are significant enough, I leave it alone. I won't do the other side. So that's basically the way I structure it. Since it's mostly right dominant in most people, we start on the right side because we have the highest percent and chance, right, of getting lucky with the side.
So let's just pretend that I'm coming to your clinic and I'm going to get my stellate ganglion block, and we're going to do my right side. Why don't we just talk people through what would happen? So I would arrive at clinic, and then what would happen?
Well, first, I would do the history and an exam. So really, I want to make sure that you would benefit from a stellate ganglion block. And the way I do that is determine if you're having dysautonomia issues or not. So that's step one. So once you come into the clinic, we'll get you comfortable, we'll get you to change, because we don't want to get cleanser on a bra strap or a t-shirt. And I'll come over and I'll explain everything again, even though we would have done that already anyway, but some people forget. And we go over side effects and things that um, could happen, because mainly I don't want people to freak out or be upset with something that they didn't expect.
Mhm.
So, and the things that we talk about are this. Number one is the hoarseness or the lump in the throat. And that happens, had nothing to do with the actual procedure. That's a side effect, because at C6, at the level that we're talking about, cervical level, there's a little nerve that comes off the vagus nerve. Again, see, there's the vagus nerve.
Mhm.
It's called the recurrent laryngeal nerve, and it powers our vocal cords. And it's a very tiny, small nerve, and it doesn't take very much local anesthetic to touch it to make it not work. And that's where you get the hoarseness and or lump in your throat. It doesn't tell you whether you had a successful block or not. Getting the hoarseness is really not relevant. It's an annoying side effect that I don't like, but it just happens frequently enough that it's worth mentioning. The second thing is that some people feel like they have shortness of breath or difficulty taking a breath. This is more of a sensation rather than an actual hypoxia or problem breathing. And we can prove it to the person, because on room air, we'll look at their pulse oximeter and it'll say 98% or better. So these effects are short-lived and they will go away. The other part is what we're looking for is the Horner syndrome. So what is that? So we're cutting off the input of the sympathetic nervous system to your face, specifically your eye. So we're looking for a droopy upper lid, and that happens because there's a muscle in the upper lid that's partly controlled by you voluntarily, but part of it is controlled by the sympathetic nervous system. And that's to make it easier for you to keep your eye open. If it wasn't there, you'd be kind of half-masked. Your eye would be partially closed. Remember, we talked about pupils. So the pupil will be, we're blocking the sympathetic system, which makes the pupil dilate, so it has to be small, right? So we're looking for a significant decrease in size of the pupil on the side that's blocked compared to the side that's unblocked. And it should be at least 2 points. I prefer 3. So I'm looking for a 3 millimeter reduction. That'll be ideal. The eye gets really red because the white of the eye gets blood flow. So it appears like you have pink eye. It doesn't itch or anything, it's just temporary, but it's there. Lastly, I look at stuffiness of the nostril. Again, sympathetic is all about making you survive. So it's going to shrink down the tissue, make it easier to take nice deep breaths, right? When you take that away, the nose becomes stuffy on one side, but not the other. There's another one that we look for, but doesn't happen every single time. And that's, there's no sweating and there's an increase in temperature because we're taking away the sympathetic input. So sometimes we'll see flushing like on the face or the neck. And it's the weirdest thing if you ever see it. It's right halfway down the face. Half is going to be red, half is going to be normal. Or it could be on the neck, or it could be on the arm, or it could be part of the chest. Flushing on the affected side, but dry. That's the thing. It's flush, but there's no sweating on it. But you see it once, it's just startling. Doesn't happen
So,
every single time.
so I come in, you tell me all of these things that are going to happen, and
Yes,
so I'm not freaked out about them when they
right.
happen. Yep. And
All right,
then
all right. Sorry, I
no,
lost
this is good.
track.
We want to know.
We take you to the procedure room.
Mhm.
Okay, we lay you down, make you comfortable. You turn your head slightly away from the side I'm working on, and start the ultrasound. Okay, that's once everything has been prepped, sterile
Mhm.
gloves and all the medications have been drawn up. Start looking at the landscape, because first things first is safety. So you have to make sure that the spot you pick is a safe trip from the skin to where you need to go to. and I check twice. So all the way up and down, I want to make sure I'm completely aware of what's going on. And then I'll say something like, you're going to feel a pinch on 3, and I count it down. And a pinch and a burn lasts about 2-3 seconds. And then after that, all there is pressure and a popping sensation. Now, the popping sensation comes from penetration of the barriers between muscle. So as the needle goes through from one muscle to the other, it feels like a pop, like a balloon pop. The first time people are startled, that's why I mention it. But after that, it's usually really smooth.
And then you repeat it for the second injection?
Yes. So I don't just inject in one spot, basically put the needle in one place and inject. Once I start, I pick a spot I like, and then I start injecting the medication. I see how it spreads. Is it spreading around the area that I want, or it's not? If it's not, I just adjust the needle. I may inject 1 spot, 2 spots, or 10 spots. It really depends on how it's spreading. And then yes, I will repeat the process again at C3 or C4, depending on which looks better.
And then you're done. You clean me up. Can I feel something right away?
You're gonna
Am I
feel
getting this
it after
horner
the first
syndrome right
level.
away and my eyes drooping
Yes.
like right then? Like before I get off the table, we're starting to see if it was effective by looking at some of the
Oh
side
yeah.
effects?
Yeah,
Yeah.
even before I finish the procedure, you'll be feeling all those things that I mentioned.
Okay. And then how long do I need to wait before I can like get up and sort of walk around and get dressed?
So in the beginning, we wait a few minutes to make sure there's no issues, and then we'll sit you up first. Now, some people are going to get dizzy, and that's normal. And that's because we're increasing blood flow to the brain. So things are shifting with blood flow quite a bit. Okay, some people will feel pressure in the head. Some people will feel dizzy. Okay, and we'll have you lay down for about 15 to 30 minutes. It really depends on how you're feeling. Some people have changes in their vital signs, so we watch for that.
And then can I drive right after the procedure? Do I need to take it easy for a day or two? Like what is sort of the immediate follow-up look
Okay,
like?
while you can drive home, I usually recommend having somebody with you to take you. And it's not because of the symptoms or anything. It's just that a lot of people um, they feel like a weight's been lifted off. Some sleep for a long time. You may even fall asleep right in the recovery room. And the reason is we're taking that foot off the gas pedal. We're removing the anxiety, or removing the fear, we're removing that sympathetic overdrive. So that, I
And then
mean,
how long am I going to be hoarse? How long is it going to take me to sort of adjust to my new normal?
so I change what I inject depending on what I'm treating. So on average, it's about 45 minutes to an hour. But occasionally, for certain things, I may add a longer acting anesthetic, and it could be 3 to 4 hours. It really depends on what I'm treating.
Okay. And then when you said you don't want to do both sides if you don't need to, how long in between like doing one side would it be before you decided if you need to do the other side or not?
So, what I prefer and what happens are 2 different things. So, if somebody's local and I can bring them back in a week or two, I'd rather do that. But somebody flying in from Australia or UK or Canada or even another state, and they're not able to stay, I still try to do it over 2 days if it's at all possible. And that gives them the night to
Mhm.
sleep and see how they feel the next morning. Now, they may not even feel completely well after the block initially, but after that night, they feel completely different. So some symptoms are immediate relief, some are not. So really having that night helps. If they can't, if they have to fly in and fly out, I can't do them the same day, but I prefer to do them over 2 days if possible. You can do them about an hour and a half to 2 hours apart on average.
Okay. But you'd like to have at least a day in between would be better.
I do, and that's mainly because to see if they even need the left side.
Right.
Um, Occasionally I start on the left,
Oh.
but most often I'll start on the right.
And while I'm in your office, am I able to, if I'm not having the eat, because I know the eat throws a different layer, and we're going to talk about that in a second. If I'm not having the eat, am I able to keep a mask on throughout the procedure? If I want to wear my PAPR, can I wear my PAPR during the procedure? Like what kind of, precautions can I still take while I'm in there doing
Sure.
the procedure?
So I'm in the mask pretty much the entire time. I leave it up to patients, whatever makes them comfortable. We have HEPA grade, medical grade filters in every single room, including a huge one in the procedure room. So I mean, we take all the necessary precautions. All my staff wear masks.
Mhm.
I mean, it's really as clean as you can
Right.
make it.
So, but you can do the procedure with someone who still has their mask on or has their PAPR on as long as you have access here, or is there some reason why they couldn't have the mask on? Besides, I know you can't do
As
that with
long as
patients.
it's not in my way, it's fine.
Okay. Okay.
I mean, obviously, if they're wearing like a gas mask or something where it's covering the neck, then I
Yeah.
can't really work.
Mhm.
But as long as I have access to the neck, it should be fine.
Okay. And then now speaking of the eat though, do you do the eat procedure? Well, first of all, let's talk about what the eat procedure is, how that works in conjunction with the block, and then you can tell us, do we do it the same day, before, after? How does that work? Because I know they work hand in hand. So you want me to pull up the slide with the eat and you can start talking about what the eat is?
Sure, sure. And I see a lot of comments coming in about injections and stuff. It's actually not as bad as you think. I've done 10 and 11-year-olds, and remember, these people are awake. These are kids, and I talk them through it. And very rarely does anybody say, it was really uncomfortable or painful, or, I wish I hadn't done it. Really, it's well tolerated. And we're talking about the stellate ganglion right now, not EAT.
Mhm.
But
He's injecting an anesthetic. He's numbing,
yes,
sets
there's
of
no
nerves. That's what's
steroid in
happening.
there. It's
Yes.
really just an anesthetic, and that's what does the work. Okay. And like I said, it's not as scary as you think it's going to be. As bad as you think it's going to be, I promise you, it's not. And every single person I talk to basically agree with me on this.
The
All right,
dentist
so
is probably
let's.
the lidocaine at the dentist is probably worse.
Oh yeah, oh yeah, oh yeah, way worse. um, okay, so let's talk about EAT. First off, what is it? It's epipharyngeal abrasive therapy. Now, there is no such structure as an epipharynx. I challenge you to look it up. You won't find it. We have the nasopharynx, we have an oropharynx, but there's no epipharynx. It was a term coined in Japan in the 1960s to refer to both those areas and the surrounding area. Okay, so I said Japan, and it's been done in Japan since the 1960s. They kind of incorporate this EAT procedure for chronic epipharyngitis, for many different conditions. So what made it interesting for me was seeing the dysautonomia aspect and how it treats certain things that are being driven by problems inside this epipharynx. So we have a mucus layer there, or biofilm, whatever you want to call it. It doesn't clean out. You can't rinse it out. You can't neti pot it out. It has to be physically removed. Okay. So that's the first part of the procedure, and that's basically manually rubbing every part of the epipharynx. There's going to be some bleeding in some, and that tells me that the area is very inflamed. There's going to be no bleeding in others. So I graded from 0 to 4, 0 having no bleeding, and 4 having bleeding every time I even look at the area. It bleeds, even if I don't touch it. The second part is the application of zinc. Okay, so zinc is an anti-inflammatory, it's an antioxidant, and by the combination of rubbing the area plus applying the zinc is what does some of the work. The third thing is the vagus nerve. Okay, this is a way to stimulate the vagus nerve, which innervates the throat and the nasopharynx in a way that you can't do any other way. You can't do it on the ear, you can't do it on the neck. This is a very unique way of activating the vagus nerve. So those three are the main mechanism of how it works, okay? So activation of the vagus nerve, decreasing the inflammatory cytokines, because once the area is inflamed, it is constantly secreting low-level inflammatory markers, and cytokines are one of them. Okay, interleukin 1, interleukin 2, interleukin 6, interleukin 8. These are nasty inflammatory markers, and they cause inflammation. By doing this, you're also suppressing the inflammatory cells from gathering together and secreting these things. So that's basically it in a nutshell. It sounds easy, but it's actually not. We'll show you some pictures here in a minute, but it's not technically a straight path. So let's talk about how this is done, okay? The area is numbed and decongested, okay? This is all done topically. There's no injections here, okay? It's all done with the topical atomizer. So it's a device that basically makes a very tiny little particles that get into your nose and get into your back of your nose and back of your throat and make everything numb, including the septum. Okay, so that's the first part. The second part is using a very thin, flexible camera. Okay, it's thinner than a pencil and it's bendable. It lets me look in all 360 directions, 360-degree direction. Okay, so I guess I will go over more about how it's done when we get the picture. So let's go over what it's really good for. And certain things I discovered on my own because it was never published anywhere else. But one of the biggest things that I found this helpful for is for head pressure and headaches and face pressure. I've had patients when we've done the stellate ganglion and everything else was fine. All the other symptoms went away except that one, that constant headache, that constant head pressure. Feels like your head is in a vice or feels like your head's going to explode from the inside out. So that one is a big one that I was looking for as complementary treatment to the stellate ganglion. Okay, another one that was a bit of a surprise was eustachian tube dysfunction, feeling like you're underwater, like you just dove down and it's still there, feeling like pressure in your ears, and even tinnitus. So the eustachian tubes open up right there where I'm working, and occasionally, or actually a lot of the times, I will see a lot of inflammation around the eustachian tube openings. Okay, so that's a big one too. All the things in the head and face and throat and neck area are improved post-procedure. So I've had patients who have regained their ability to sing. And this is even after we've done a stellate ganglion procedure and they still were hoarse or their voice was changed. This procedure is really helpful for that. People are having a chronic cough or chronic sore throat. It helps with this as well. Okay, this is what we call the laryngeal irritation symptoms, right? So things like snoring, you may think you have sleep apnea, but it may not be sleep apnea. It may just be a problem with the larynx. Sore throat, laryngeal discomfort, trouble swallowing, trouble with your voice, okay? Speaking of sleep apnea, it can improve some of the issues with sleep apnea without a CPAP. So things like insomnia, snoring, daytime sleepiness, it can improve. Gastrointestinal problems. Now, you would think, why would doing something in your nose or throat improve gastrointestinal? Well, it's from the vagal nerve and stimulation, okay? So heartburn, right? Bloating, heavy stomach, that may be a symptom of a vagal dysfunction. Some of the autonomic nervous system that Kara mentioned in the beginning, the fatigue, the brain fog, the depression, the anxiety, that also can be relieved due to the vagal stimulation. So a lot of people, they're talking about vertigo, right? Feeling dizzy, lightheaded, room spinning, or they're spinning. It may help with this as well through the eustachian tube part. Nose related. So let's talk about runny nose or congestion or nasal irritation. This helps with that as well. Lastly would be the postnasal drip symptoms. Okay, so again, the runny nose, the postnasal drip. So those are kind of the main ones. Okay, those are the main symptoms that are affected by this EAT procedure. So I know they show this swab going straight back, but it's not always that simple. People have different anatomies, they have different size turbinates, and you don't want to cause a nosebleed. That's why it has to be guided by a camera. And some people, they'll have a very large or prominent adenoid glands, which are similar to tonsils, but they're in the back of your nose instead of the back of your throat. Okay. If they're really prominent there, I know there's a lot of activity. So in other words, there's a chronic infection or chronic irritation, something that's causing them to be that prominent. Most people without long COVID won't. It will look completely flat. There won't be any glandular material there. So that's kind of it in a nutshell. Let's go back to basically how it's done. So once the camera makes its way back to the back of the nose, the epipharyngeal area, I will examine the entire area and see if the eustachian tube openings are inflamed, if the adenoids are prominent, if there's a lot of irritation or mucus in the back of the nose. Now, normally it's not supposed to be there, but with people with long COVID, I believe that there's a chronic epipharyngitis that's occurring in the majority of people. Then I will pass the nasal swab dipped in zinc, and I will start to work on the epipharynx. Now, like I said, it's all about manual rubbing. So it's systematically rubbing from one side to the other, from top to bottom. And if the eustachian tubes are inflamed, or if a person complains of ear fullness or hearing loss or tinnitus, I will work on the eustachian tubes as well. Now, I know the next question is going to be, well, how many times do you need to do this, right?
Yeah.
You there?
Yeah, I'm here. Can you hear me?
Yeah.
Yeah.
Sorry, it's storming out here.
That's okay.
So how many times do you need to do this? Well, it really depends on two things. One is how inflamed the area is. Okay. The more inflamed it is, the more treatments you will need to get it from a grade 4 to a grade 0. It's just the nature of it. If it's a grade 0 to begin with, I mean, that's it. I mean, you probably don't need another one.
Okay.
Okay.
And with the SGB, so if I come in for an SGB, do you do the SGB and the EAT at the same time, or do you do one and then we have to wait a day to do the other, or how does that timing work?
Okay. So if we're combining an EAT, in other words, I don't just do the EAT on everybody. I have a screening form that I use to score. And if you score above a certain number, then I will offer it. If you score under that number, I don't offer it. I prefer to do it this way. If we're gonna do both EAT and stellate ganglion together, I'll do 2 procedures on one day. I typically don't like to do 3 on one day if I can avoid it. Having said that, occasionally I have no choice, but I will do the right side followed by the eat. Okay, and then I'll let a person go home or go to their hotel and rest and see how they feel in the next morning. Now, before they leave, we will discuss what I found on the eat. And if I think there's a lot of inflammation there or I've graded it high, I'm going to tell them how many times I think they'll need. It's an estimate. I won't know until I see how it progresses over several eats. I've taken people from a 4 to a 0. So somebody who's a 4, I prefer to wait longer. So I don't want to do that in a week. Anybody else, I will offer it between 5 and 7 days later, the second one. But somebody who's a 4, it's better to wait 2 to 3 weeks or even longer. And this is from experience,
Mm-hmm.
because I know how long it takes between procedures. As far as side effects or complications, I mean, I have not seen a nosebleed, but you may get some blood tinging, like if you spit or blow your nose, especially if they're on a higher grade. You feel somewhat like a burning or heat sensation in the back of your nose for a day or two, but it varies depending on the grade.
Okay.
So
So it would be like if someone is local, it's sort of a process. If someone's coming in from out of town, you do your right side and your eat, and then you assess. But the soonest you would want to repeat and eat would be at about a week, you said?
that will be the soonest. 5 days would be the soonest, and that's to allow everything to kind of settle down. And it
Mhm.
does take that long. You cannot do it the next day or the same day. The work of what's happening needs time, and it does improve from one to the other treatment, which is amazing to watch because you're watching it improve each and every time.
So on average, you said if it's a grade 4, it would take multiple, but if it's a 0, you don't have to do it again. It just depends on what you find.
Correct. If there's no if it's a grade 0, and it's pretty rare to see a grade 0, because like I said, I use a screening form to see who actually needs it and who doesn't. It's very rare to see somebody have a grade 0 and score high on the form.
And do some people just come to you for eat and
Mhm.
they don't do the SGB, they just do the eat part of it? And
Yes,
how would you
I
sort of
have
pick?
well, if they score high on the EAT questionnaire, I'll offer them to eat. The SGB part comes in if they also have a significant dysautonomia. Not everybody chooses to do that, but I've seen results with both together, separately. So there's some decision process involved, but uh,
Yeah, it's fascinating. Very, very interesting. So we do have quite a few questions in the chat.
sure,
Maybe we'll start answering some of those questions since we sort of have the nuts and bolts of how both of these procedures work and what they can help with. The first
sure.
question is, what percentage of patients have you found respond to the SGB?
In my clinic, greater than
Mhm.
90%. And the reason is two different things. One is I select my patients. I don't offer it across the board. You want an SGB, come on in. I don't rotate a sign in front of my office. SGB's here. I select my patients who I think will benefit from it. And let me tell you, I meet with plenty of people who I say, no, you're not a candidate for it because I don't think you'd benefit from it. Um, so that's the first. And the second is my technique. It's something I developed over the course of doing 4,000 plus procedures. It's very different from what I was taught when I first trained. Okay, very different. I mean, it's pretty much its own procedure. I should call it, the Groysman procedure, but whatever. I mean, my point is it's very different from what I originally started. It has increased the efficacy rate significantly the way I do it. It's also safer.
Well, that's
So
one of the questions that we have. Has it ever made someone worse? And if someone got worse with an SGB, how would they get worse?
in the beginning, when I was seeing, I guess, more uncompensated POTS, we're talking about like maybe 2, 3 years ago, I sometimes saw worsening of the POTS symptoms temporarily. So either dizziness would be worse, or the brain fog. I'm not sure if it's because it was the uncompensated POTS, or because uh, sorry, I lost my train of thought. Because we're just basically changing the blood flow, so things need to readjust. But typically a week or two around there.
Okay.
If I were to see it, it was in the minority of POTS people. At one point, I said I'm not going to do it.
Mhm.
Anybody with POTS or uncompensated POTS, but I really haven't seen this in the last 2 years. So I'm not really sure what changed. I mean, it may have been my technique. It may have been the way long COVID presents now compared to before, but I have not seen it.
Well, that ties right into another question that we have. Does it work better for certain subtypes of dysautonomia? So the hypergenic or the hypovolemic, does it matter which kind of dysautonomia? Or because it's all sympathetic, parasympathetic, it works equally for all kinds.
It works for both, but it'll work for the hypergenergic much better, because that the goal there is we're stopping the adrenal dumps, or the secretion of epinephrine, norepinephrine, and it seems to work for both though. So one other thing I've seen is anxiety. Sometimes if you block the non-dominant side, it can make the anxiety worse for a couple of days. Usually 1 to 5 days typically.
Okay.
But it's not common again. But okay, yeah, I'll let you do the questions. I don't wanna
Sure.
jump on that. That way you choose.
Okay. So if someone's had an SGB with a different provider and it didn't work, would you think that they should try it again with you? Is there enough difference in what you do and what somebody else does? Or would they have just failed it?
No, so first I'll get more details
Right.
about what happened. I mean, first off, I wanted to know which side they did. Okay. Second, I wanted to know if there's any effect, any changes, worse or not, or worse or better. I want to know. And third, probably the most important thing is I wanted to know which parts of the Horner syndrome they had and for how long. 9 times out of 10, they didn't have any Horners because they weren't anywhere near the stellate ganglion. But my technique is different enough that I think it's worth trying. If I think they have dysautonomia. Now, the problem is like I said, I'm very selective in
Mhm.
who I offer it to. Other docs are not. They're really just technicians. Anybody who walks through the door gets the block. It doesn't matter what symptoms you have. It doesn't matter if you have long COVID or not. It doesn't matter, if you walk on your hands or your feet. They get the block. They walk in, they get the block. I know surgeons like this too, by the way.
Mhm.
Um,
Yeah.
everybody who walks through the door gets cut. But my point is that makes no sense to me. So if I evaluate a patient, I say, guess what? I don't think you have this dysautonomia. I'm not going to offer it again. Um,
Right.
if there were complications from the original procedure, I may hold off.
And similarly, if they did only like the C6 level, they only did one spot, is it worth trying it again for to hit it, in both spots that you do?
Yes, yes. Not only do I seen it in my clinic, but there's one study actually comparing it for PTSD specifically, comparing doing C6 compared to doing a C4, C3, and C6, and there is a statistical difference. And I think especially if there's cognitive problems, that C3 or C4 really makes a big difference.
Well, that's good. That's good to distinguish from. And we should go ahead and say our disclaimer. Dr. Groysman cannot offer you individual medical advice on your specific case in this Zoom. For that, you will need a consult for him. This is all general advice, and you'll notice that I'm generalizing some of the questions for that reason. We can't really tell you on a Zoom call particular details about your case or medical history. We can just tell you in general, what Dr. Groysman has seen through his experience. So.
And since you mentioned that, I'm also going to mention if you guys hang around to the very end, there's going to be two things. One, I'm going to discuss some of the books that I've written. And the second thing is a surprise. And I'll be giving away several chapters of the complete Long COVID Handbook, the second edition. And it's volume 1. My goal is to do 5 volumes. I've only gotten to the first 2, and I got sidetracked writing other things, other books, mainly because of requests or asks. But my goal is to complete all 5 volumes, maybe with Kara's help on some of them. But yeah,
Yeah,
so
we'll share this with you just as soon as we're done with the Q&A. We have all the details for your surprise. What is there any need for to take something for pain before or after for the burning of the EAT? Is it that intense where you would need a painkiller?
I've only had, I mean, granted, it's not the most comfortable thing, okay, the burning, but it's tolerable for 99.5% of people. Okay, I only had one young boy who had a hard time post procedure, who had more burning. He was a higher grade, and I knew he was going to be burning, but the problem is you don't know ahead of time. Even if you
Mhm.
score high or low, it doesn't always correlate to a grade 4. So you just don't know there until you get in. And outside of him, though, I have not had anybody who said it was so bad I couldn't stand it and needed some pain medicine. Okay,
Okay.
it's I guess it feels similar to just kind of having something in your nose, like maybe diving and having water or chlorine in the back of your nose. It's burns. It's temporary. It's short-lived. If it's really bad, then I recommend like gargling with some salt water, warm salt water, or baking soda, or using a plain saline nasal spray to just moisturize the area. It really won't be longer than a day or two for most people.
Okay. If someone has had an SGB before and they have frequent sinus infections, the SGB help their tinnitus basically, but not much else. Would you recommend the EAT and repeating the SGB for that person, or would you just recommend the EAT procedure? Is there, if they didn't respond to it before, would it work better in combo with an EAT, or would just EAT be more indicated in that case?
So I'm collecting a lot of data, but both on single SGB, single EAT, and combination. But I haven't had a chance to analyze it yet. But what I would find out first is did the SGB help with the tinnitus? For how long did it help? Which side helped? So that would help me decide, if it helped for a day or two, I probably wouldn't repeat the stellate for that alone.
Mhm.
I would want to know why the person is getting constant sinus infections, and it may be because things are inflamed and closed up. In other words, the sinuses can't drain. Now, of course, you could go and have sinuplasty or turbinectomy and do it that way, but I have a feeling, especially with long COVID, you don't need to. Now, I know the ENT guys probably won't be happy with this, but
Well, you could also have some immune system impairment from your COVID infection that, maybe bears looking at your mitofunction function to shore up your immune system, right? There's lots of different reasons. So that's why it's so important to have somebody like you look over the history, look over the symptoms, and then try to suss out the nuances
sure.
for
And you
all
need to
of
look
these
at
causes.
IgA deficiency as well, because that's
Right.
one of the big ones to protect your respiratory tract, including your sinuses and your gastrointestinal tract. I mean, yes, if you're getting frequent infections, then I'm going to be digging in a little bit more before just offering procedures.
We're seeing a lot of natural killer cell deficiency after COVID. 2 or 3 months post COVID, those NK cells are going.
Well, we know
So,
that's the case, right?
yep, yep, exactly. Um, what's the best way to reach you? That would be through the covidinstitute.org website. Is that the best way to intake for the clinic?
So the easiest way is just to do the contact us on the
Mhm.
homepage. It's on most pages. Um, you can also send an email to H. Luke. I think somebody put that on there. She's one of our medical assistants, and she processes any new questions or requests for consults. HLuke at reliefbeginshere.com. But that's kind of the easiest way. Once we've made contact, we'll send all the forms to be filled out and go from there. So yeah, it's pretty easy, and I typically look at that stuff 7 days a week. So if there's some kind of urgency, um, we had a we have a patient who is trying to make her son's wedding. It's her only son, and we're trying to accommodate that because the wedding is coming up really quickly, and she doesn't feel that she can travel, and um, so we're trying to come up with strategies.
Sounds like you guys are awesome. So someone wants to know, what is uncompensated POTS?
So it's basically POTS with the full symptoms going. You're not taking any medications or treatments to control this, to control the heart rate, to control the blood pressure. You stand up and you fall down. You stand
Yep.
up and your chest feels like it's a beating drum.
Mhm.
Uncompensated POTS. So if you're if that part improves, or you're medicated, where your heart rate is better controlled, your blood pressure is better controlled, um, at least in the past. As I said, I have not seen any issues at least for 2 years, maybe more. So whatever changed happened 2 years ago. I don't know if it was the condition itself, if it was my technique, if it was
Mhm.
something else. I don't know, but it has not really shown itself in over 2 years.
Well, that's good. Here's a great question. What about current, supplements, adaptogens, adrenal support products, thyroid meds, all those kinds of things? Before someone is going to get an SGB, do they need to discontinue anything? Should they just continue with their normal medications? What have you seen, or what do you recommend before you do the block?
Sure. So first things first, we review all the history. What kind of medical problems you currently have, and just because you have long COVID doesn't mean you can't have heart problems, you can't have lung problems, you can't have kidneys or liver or thyroid or something else.
Mhm.
Okay, and we want to make sure that it is long COVID that we're treating, and not hyperthyroidism, hypothyroidism, or pituitary tumor, or renal failure, or hepatitis. Okay, so that's the first thing. You have to flush out that it is long COVID. Number two, you want to make sure it's dysautonomia. Okay, so as I said, it's about just narrowing it down, to make sure that what you're treating is what you're treating. Now, dysautonomia, you know this, that there's really not a lot of oral things you could take. Yes, you can mask the symptoms, you can lower your heart rate. There's a couple of different medicines that do that. You can increase the blood pressure, you can increase the blood volume. Okay, and you can work on some of the cognitive things. I mean, people know about things like low dose naltrexone or Abilify, or you mentioned the.
Mhm.
So there's I mean, there's a lot of different options, but really, are we treating dysautonomia, or are we just putting a band-aid on? So that's the thing. Yes, you can increase your parasympathetic tone for sure. I mean, there's several things that can do it, but there really isn't vitamins or supplements or peptides that really help with dysautonomia. I mean, the way you treat it is usually procedurally, which is vagus nerve stimulation. Okay, that's something people could do at home.
Mhm.
You don't need to go to a chiropractor's office or doctor's office to do it. It's something that you can do in your own home. It's very easy to do, and it's effective for a lot of people, but it's a slow process. Okay, we're talking about 90 days minimum. Some people need 6 months. Some
Mhm.
people don't like to wait. Okay, because the steps are so gradual and small, um, people may not even realize they're getting better.
Mhm.
So
Well, I
vagus
definitely
nerve
think
is
there's a lot of frustration in the just in general in the dysautonomia community, including the long COVID community, about how difficult a condition it is to, manage. And a lot of the treatment out there is, symptomatic, from the compression garments to the elevation of the head of the bed to the hydration, all of those things.
sure.
Like you said, you're not really hitting etiology as much as you are band-aiding the symptoms. So it's good to have something that might be able to sort of do a reset for sure.
Right. But the three things we have are vagus nerve stimulation, stellate ganglion procedure, and the eat. Now, if for any reason all those three don't work, then yes, symptomatic is all you can do, and you can still make a decent quality of life for a person by treating it symptomatically. But I first prefer to see if we can knock it out completely.
Mhm.
Um, and not
Yeah,
have to
no,
deal with, the blood pressure medication, the heart rate medication, the cognitive stuff. So
yeah, it's definitely a challenging condition. There's some neuroinflammatory component to it as well. And in the milder cases, sometimes you might treat the neurological inflammation and resolve the dysautonomia. But for a lot of patients, it's just a one thing after another. So it's great that there's something that could give them, more lasting relief and more lasting hope. Um,
I
there's
really think
questions.
I really think it's the dysautonomia that's driving the neuroinflammation, though.
Chicken egg. Chicken egg. We've seen it,
I know.
both ways, right? If
Right.
you give, some people, they have a highly neuroinflammatory component, usually like an autoinflammatory kind of
Yes.
condition. And then, we give them steroids or immunomodulation, and then their dysautonomia gets better because it's driven that way. But it certainly could be driven back and forth. But in long COVID in particular, then I'm sure the dysautonomia is a huge component, at least, of the brain fog and the cognitive symptoms and that energy drain on the body. It's just a huge energy suck
And,
when your
and, and
autonomic
and what's
functions
crazy,
are.
Kara,
Yeah,
is the response can be literally from the time you get the procedure to the time you're in the recovery room.
right.
And that's kind of what's puzzling, is because if it was neuroinflammation that causing it or driving it, you can't resolve it that quickly. Um,
Well,
typically.
I guess we're talking about stimulating a nerve, though, right?
Yeah.
So you can stimulate a nerve that quickly. If you have neurological inflammation that's irritated the nerve and got the neurotransmission off base, and then you stimulate the nerve, and basically get the signaling running the way it's supposed to, I suppose the cause of the reason for the nerve being off base could vary. But yeah, we could probably have lots of very interesting
Yeah, yeah.
conversations about all these etiologies. But the people want to know, is
Yes.
there say someone, yes, they've got long COVID, yes, they've got dysautonomia, yes, they qualify for your screeners, but are there other kinds of medical contraindications that would stop you from performing these procedures? Are there some other medical reasons why you would not be able to offer either the SGB or the EAT?
Yes. So let's talk about SGB. Really, there's very few contraindications, but you have to know about them. Number one is if you had a chunk of your neck removed, either from trauma or from dissection, let's say from a neck tumor. The anatomy is so distorted that I wouldn't feel comfortable attempting it. I'm fine with neck fusions. I'm fine with Inspire. I've actually done it many times already with the wires coming through, or if you have a vagus nerve stimulator, same thing. Um, The second thing is blood thinners. I mean, if you're on triple therapy or on some heavy duty anticoagulants, okay, I want to be
Mhm.
clear. The anticoagulants are more of an issue than the antiplatelet ones. But I just mentioned, carotid artery, vertebral artery, inferior thyroidal. There's a couple other ones that don't have
Mhm.
names, but just sometimes creep up. Vein is not as big of a deal, but artery is. And if you can't stop bleeding, it's a bit more challenging in the neck area. Okay, so those are the two main ones. Um,
That makes perfect sense to me.
Pretty much
If
anything outside of that. Yeah. I'm sorry, go ahead.
if people are on oxygen, can they still have the procedures while they're on oxygen?
I do it on a case by case basis. Um, I don't really expect there to be any problems with being on oxygen because I'm not going to nick a lung. And well, no, it's a real
I hope
possibility.
not.
No, but it's a real possibility at C7. Sometimes some people
Mm.
have the top of the lung called the cupola of the lung
Mm.
a little bit higher than it should be. And if you don't see that pleura, that's a real possibility, and it is in closed claims. Okay, so
Oh, wow.
it is a real complication. I have never seen that once in over 4,000, but that's because I'm very careful and meticulous about how I do my procedures. But outside of that, I mean, look, if you're sucking down 10 liters of oxygen just to not be short of breath, I probably may not want to do that. But
Mm.
for the most part, it's not really a contraindication for me.
Okay.
I'm not going to
Um,
block the phrenic nerve.
Good. Please don't do any of those things. I'm glad that you are so careful and that you're guided. I think you told me a story one time about a colleague that wasn't so guided, and then you showed him, and he was like, "Oh my God, I need to be guided too," because it makes all the difference
Well, it
in making
does. It does. When ignorance is not bliss, because if you don't see it, it doesn't mean it's not there. So
exactly.
yeah. But anyway, for the EAT procedure, again, anticoagulants wouldn't be ideal because you can get a nosebleed, and I try to avoid that. Um, if you have severe anatomical surgical corrections that completely distort everything, it's unlikely, but it's probably one of the relative contraindications. Even if your nostrils are small, it's not a big deal. Okay, I can usually get in because the scope is very small. But I mean, if you've had everything removed from the inside, if you have implants or something else that's unexpected, you may want to let me know. I've seen some things, let me tell you. But really, I mean, that's really it. There's not a lot of contraindications for it.
That's good. And before the procedures, like the morning day of, is there food restrictions, eat or drink restrictions? Do they need to come fasting? How does
No,
that
there's
work?
no
Okay.
restrictions. You don't need to fast. In fact, I prefer you don't because then you're hungry, and then I gotta feed you. Um, so yeah, I mean, there's really no restrictions on food, drink, or anything. You could
Okay.
take all your normal medications. Like I said, I just need to know if you're anticoagulated. That's a
That
big one.
that makes sense. And then we're getting a lot of questions about insurance. These procedures are not covered by insurance, correct?
So let's look at it this way. The procedure doesn't even have a CPT code.
Right.
Okay. What insurance covers for SGB is pain related. So CRPS, stump pain, um, like for amputation, for instance, phantom limb pain. Um, you have the whole limb removed and you have pain that way. It's really covered for pain syndromes only. What is covered? It's covered under fluoroscopy. It's covered one shot with steroid in C6 or C7. That's it. Okay, it's a very different procedure than what I do anyway. So
Mhm.
even though there's a code for it, it doesn't represent what I do. So that's one of the reasons that that we don't accept insurance for it. The second is the amount of time I spend with patients during these procedures and post is more than what insurance allows us to do. And I don't feel I can adequately and safely take care of patients under the insurance guidelines. So that's kind of what it is. As far as eat, like I said, like Kara said, I'm really the only doctor outside of Japan that offers it. It's not that other doctors can't do it; they don't believe in it. I've done the research. I've done many of them, and I understand how it works and why it works.
Right. Yeah. So we're lucky to have you in the US to offer the procedure to us. Now, let's talk a little bit about timelines too. First of all, what's the wait list in terms of getting an appointment with you? How long does it take if someone were to email today and fill out the paperwork? About how long could they expect to wait before there's an opening for you to consult with them and then for them to have their procedure?
Sure. So part of what we do is some triage to see if it's urgent. Like for instance, like that young lady I was telling you about. I mean, she's trying to make her only son's wedding in a couple of weeks, and it's really important to her. So we try to squeeze people in. I mean, that may mean I work later that day or earlier, or I may open up a Saturday. My point is we try to see how urgent it is, and I try to get people in as quickly as I can. Having said that, I mean, yeah, there is a bit of a waiting list, but like I said, I do manipulate some of the schedule based on people's needs and requirements. I mean, some people can't make it before 3 or 4 months. Some people need it to be done yesterday. I mean, I'll do whatever is possible. I mean, obviously, um, there's issues with keeping clinic open later than usual hours because that means overtime for staff. But I try to do as much as I can to help as many people as I can. So the
Well,
answer
and
is
just
it's
talking,
variable.
sure. And just talking about cost, there's a lot of cost questions on here. If you want to give a quick rundown of the cost, I think your costs are actually really reasonable, but there's a lot of people asking how much of these procedure, or would you prefer them to contact your office for
It's
that?
probably better to contact my office because honestly, I don't remember.
Yeah,
I focus so much on the clinical and the medical that I don't keep track of price changes and things that occur on the financial side. But I think it's reasonable. I mean, and
if I remember, it's like it was less than $1,000 to have it to have the SGB done, if I remember correctly.
I believe so. But again, I don't
Right.
know the exact number off the top of my head.
Mhm.
Um, so I
And
don't
I
want to
don't
give you the wrong number.
Sure. Yeah. So when you contact Dr. Groysman's office, they can tell you exactly the
Yeah.
cost of. There's one cost for the each, and then there's one
Yeah,
cost for
I think
each
both
side
of
of
them are under
SGB.
1,000, but I'm not 100% sure. Again,
Mhm.
because I'm not really involved in that part as much as I
Sure.
should be.
Oh, no, it's good that you're not. It's good you can focus clinically. Um, Thyroid removal, bulging discs, are any of those contraindications for um uh the SGB?
For others,
Also,
probably not for me. I
okay.
have seen and done enough of these that I am comfortable with just about any variation in anatomy that you could throw at me. Um,
Mhm. And what about with mast cell activation, have you seen improvement in people with MCAS when they have the SGB, or is it not a related condition?
it is related because of the immune activation from the sympathetic overdrive from the fight flight. So indirectly, it has improved for most people. I'm not going to say 100%, but a lot of people have seen improvement from the MCAS or the overactivation of the mast cells.
All right. Well, we're coming up on time. I do want to go ahead. Let me share my screen for a second. There's a lot of questions. So the website is covidinstitute.org. The phone number is here. There's lots of information here about the
Oh, you see
procedures,
that
how to get
contact us? If you scroll up for a second,
sure, right
just
here.
yeah, right there in the yellow, that's pretty much
Mhm.
how to get in touch with us from anywhere around the world. We even have translation services for 240 languages, dialects, even sign language, ASL. So, I mean, pretty much any language, any dialect, we can accommodate. Um, Before we go though, let's put up those two things that we talked about.
Absolutely. I was just gonna say here
Ooh,
are the books, and we here have also a list
okay,
of
yes.
the different.
So what I wanted to break down is if you ever want to know where what I've published, that's the top line. Okay, that's me. I'm the author, and it will have all the latest when I publish. It doesn't always come through if you don't check. The books I've written so far has been 5 books, but I made it into 4 because I'm on the second edition now of the Complete Long COVID Handbook, and this book is written for 15 to 18 or older. Okay, it has references in every chapter. That means if you want to look up where I'm getting my information from, you can. I break everything down from causation to including all the 4 causes, including treatments. Okay, why it happens, how it happens, and how to treat it. Then I break it down on the volume side. So volume 2, which I didn't put down here for some reason, is the dysautonomia, and that really just focuses on dysautonomia. So POTS, vagus nerve stimulation, all that, including all the conditions that
Yeah, it's right here.
cause dysautonomia are there. Then I wrote, I was supposed to continue 3, 4, and 5, but I got sidetracked, as I said. The Easy Long COVID Handbook was written for about a 5th grader. The reason is some people with brain fog and younger readers were asking for something that's easier to process and understand. So that book was rewritten basically to make it easier to understand using everyday examples and break down the concepts even further than the second edition Long COVID Handbook. Okay. Hang on, go
Oh,
back.
oh, sorry.
Living the de-aging life is kind of an offshoot, okay, and that is not what it sounds like, even though what people think it is. It's really looking at accelerated aging due to a chronic illness or chronic condition like long COVID. Same thing happens with chronic fatigue syndrome and many other conditions. I break down what causes it. I break down how to fight it. Okay, this is not about looking younger. This is not about having youthful skin or long hair or full head of hair. It's about fighting the chronic, the accelerated aging that occurs with chronic illness. And a lot of you probably have noticed this, but you look in the mirror and you look a lot older than what your age should look like. Okay, that's what this is fighting. Okay, it works on some of the other concepts. I talk about long COVID in terms of causes. Okay, and there's 3 volumes that are still in the process, which is the mitochondrial dysfunction, the gut dysbiosis, and the MCAS. Those are to complete the set or the series of the causes for long COVID. Okay, everything is covered in the complete long COVID handbook, second edition, but it just goes into more detail in each of the volumes. All right, next. So this is a surprise. I mentioned it already. If you like and you want to sign up, there's the link to sign up. The disclosure is here, which means that it's this is a marketing thing. I would be we'll be sending things like new book publications, new treatments that we offer, anything long COVID related. You're not going to be getting car ads or car insurance or life insurance stuff on there. If you feel comfortable, click on the link or copy the link and send it in. What you will get is 3 chapters from the Complete Long COVID Handbook. This is the second edition. This is the new one. It was just published. If you really like what I wrote and you think I add value to your condition in your life, consider purchasing the book. It's not crazy expensive, and that's basically what I have to say about it. The link is
Now we're getting
focused.org/book-gift.
Yes. And this will be in the notes for all of our chats. We do have notes. Our Christina takes notes for us, and then the slides will be included in the notes as well. And we're getting a lot of questions about where you'll be able to watch the recording. So the recording will be here on our Still COVIDing YouTube channel. It usually takes me a couple of days to get it kind of rendered and then put up, but it will be posted in Survivor Corps and in our Still COVIDing groups, as well as directly on the YouTube channel. So you can go YouTube slash at Still COVIDing playlist. You can actually see our last interview here with Dr. Groysman specifically about the books. And then we'll also have this procedure update as well. So
I didn't include this in the slides or anything, but since you're showing the YouTube channel, I have a YouTube channel that I also host. There's over 50 videos, educational videos on long COVID, addressing just about every topic you could think of. If you're not tired of hearing me talk and speak,
yeah, and we can link your YouTube channel also in the community notes under this presentation as well. So if anyone wants
yep,
to go
and it's
Dr.
all free.
Groysman's channel.
So,
Yep. All right. Well, thank you everybody for being here, and thank you, Dr. Groysman, for your time. We really appreciate it. This has been super informative.
there's one
And
last thing I wanted to just cover, and that'll be on the first page. Both of our groups, I just wanted to show them. I know they're going to see it later, but just the title page.
oh, are you talking about Facebook groups?
Mm-hmm.
Yeah, I took those off because
Okay.
we encourage everybody to access this information through the Survivor
Okay.
Corps Facebook groups or the Still COVIDing Facebook groups. So
Okay.
but definitely Dr. Groysman has been very generous in posting in Survivor Corps. I know a lot of you have come there from that long COVID group, and hopefully we can do some more of these informational presentations on specific topics, and keep the information coming for people to get them some relief. So thank you everybody for being here. Thank you, Dr. Groysman. We will get this up and with the notes and the links so you can get the sign up for the chapters of the book, and also get in touch with Dr. Groysman if you are looking to have a consult.
Thanks a lot, Kara. Thanks, everybody.